Hello and welcome to All Coronary Physiology Cardio Webinar Series. Please subscribe to our channel to receive most recent webinars related to coronary physiology, assessment, and innovation. Thank you for watching. Welcome everybody. My name is Chadi Alraies. I am a interventional cardiologist at Detroit Medical Center. And welcome to our All Coronary Physiology webinar series. This is a cardio webinar series put together and sponsored by Options Medical. It's a privilege to bring this on a monthly basis. I would like to thank Chantal and Charles for all the support from Options for supporting this educational program that brings not just only clinical cases, techniques, as well as innovation in the cath lab. We're doing something new this time, and we're presenting a new platform talking about bringing innovation to hospital groups during the COVID-19 pandemic and beyond. We have an esteemed panel today, John Strong, Kerry, Riddick, and Eric Brown. They're going to talk to us about a different venue, how to navigate the system, and how to bring new technologies and innovation to your cath lab. During the webinar, a few housekeeping items. I would like you to kind of tune in and send us any questions using a Q&A box as well as a chat box. If you have any questions or to the audio, to the panel, or to beyond the scope of this talk, if you have any new ideas for future webinars, there will be no opportunity to ask questions directly. So please use your Q&A box, as well as throughout the webinar, we'll be throwing some poll questions as a feedback for the webinar, as well as things that you are struggling with in your practice. With that, I would like to start with our first speaker, is John Strong. John Strong is a 45-year-old veteran of healthcare industry with leadership experience in healthcare providers, suppliers, and service providers, and group purchasing organizations. As a co-founder member of the Access Strategy Partner Incorporation, John serves both providers and suppliers along the healthcare supply chain. John holds equity and serves on the boards of several companies and is an investor and advisory board member of Supply Clinic, Open Markets, Ricards, and Mondo Point. Mr. John Strong, please go ahead and share your screen. I'm going to take off my screen, and you can start your presentation.
Thank you very much, Chadi. It's a real pleasure to be here this afternoon with you all. I'm going to run through some material very quickly. What I'd like to cover this afternoon is really some practical applications in terms of how to bring innovation to hospital groups. I'm having a little trouble advancing this here. And really there we go. What I'd like to cover today, this looks like a rather imposing agenda, but I'm going to go through this very briefly over the next 10 minutes and talk a little bit about the environment we all live in today, both the provider and the supplier environment, as well as the patient's view of healthcare, because in the United States, it's changing very rapidly now with consumerism. And we'll talk just for a second about how value has changed, what the new normal may look like, and how we actually bring innovation to customers. And I have 6 practical brief applications, whether you're a supplier, or whether you're trying to make a case for new technology within a hospital or a healthcare organization, how to consolidate your message around value analysis and that sort of thing, so that you can really tell your story in a very succinct way. So I think the first thing to understand is that med tech is a huge category. In the United States, there's about 6,500 med tech and device companies today. They're all seeking the attention of hospitals and healthcare providers around the country. And in Europe, there's about 2,700 or 27,000 rather, different device companies, many of them who are trying to come to the United States. And so the market is growing rapidly, as you can see in the center of this slide, about 32% growth rate expected between 2020 and 2023. And this adds some complexities, whether you're in a hospital and trying to cut through the clutter to make your case, or whether you're a supplier who's actually out trying to sell these products. And you'll notice at the bottom, the North American market share of the med tech market is about 39%. So North America, between Canada, the US, and Mexico, represents about 39% of the total world in this space today. Well, because of COVID and for other reasons, the customer market, whether you're in North America or in Europe, the environment has changed. And all of these things are sort of intertwined between lower revenues, strategy, reevaluation, higher costs, enormous staff impact. And it's really resulted in a number of changes. If you look at lower revenues, for example, a number of patients have delayed treatment, and there's been some other unintended consequences of COVID-19. One of them is that here in the Midwest, there's really been no flu season at all. And as you listen to chief financial officers in hospitals, they'll tell you that that's had an impact on their revenues. If you look at the strategy reevaluation section, I think the key points here are really, in some respects, it's resulted in deferred capital spending. And so I think as you make your case for new technology, you really have to be able to position it in a way that is going to stand out from the other competition within a hospital or a healthcare system in terms of how you want to acquire some of that technology going forward. And at the bottom there, we point out that construction programs, clinical programs, capital have all been deferred over the course of the last year, mostly because of COVID. Higher costs because of PPE and other things, as well as supply shortages. Those shortages have driven up costs are certainly key. And then the whole notion of working from home, this is really bringing some challenges to everyone in terms of how you make your case in front of a value analysis committee in the healthcare system and that sort of thing. So as I pointed out, you've got purchasers working from home, you've actually got salespeople working from home as well. And I think the key message here is everything takes longer. And so having succinct messages that really resonate both with healthcare administration as well as others in the organization is really critical in terms of building your case for acquiring new technology going forward. There's really new demands for the right proof. Many administrators now have a bigger role in selecting technology than they have in the past. And we'll talk a little bit about what that right proof might look like tonight, right along with some value analysis decisions and that sort of thing. So it's definitely a changing world. The audience is changing rapidly. Certainly people are working from home, but staff is also turning over very significantly, both among suppliers and among healthcare providers. And the result of this is really the need to make your case quickly and try to get decisions made as quickly as possible. In some cases, decisions take anywhere from 6 to 18 months. And unfortunately, because of the turnover and the need to re-educate people who may come in and replace someone, getting faster decisions at the provider level are something that we believe is really necessary going forward. And then the other interesting thing on the slide is the final bullet, the Strategic Marketplace Initiative, which represents about 70 large healthcare systems around the country and around 70 of the most prestigious medical device manufacturers in the world get together and they share a lot of information. They haven't gotten together physically, of course, for the last year, excuse me, but one of their findings in a recent survey was there's high interest, as you might imagine, among sales representatives to get back in front of their hospital customers, but there's almost no interest on the part of those hospital customers in going back to the same old process of seeing sales representatives on a regular basis. And so this is something that I think needs to be planned for, whether you're buying or selling healthcare equipment going forward. One of the other key points is this whole notion of what patients' views are and the impact on providers. And certainly there's a high interest in telemedicine and home care today. We've been shrinking in the United States inpatient volume over the past few years at about 1.5% a year. But the key of this slide is really on the right-hand side. And right now in the United States, about a third of all patients want to know what a procedure is going to cost from their healthcare provider up front. And I think this number is going to continue to grow. So as healthcare providers continue to purchase more and more high-tech medical devices, they really have to be able to make a case for why this is valuable to the patient and why this is something that the patient may want to invest in. And it's not just about anymore selling to doctors and physicians and nurses in hospitals, it's really selling to the patient at the same time. The other thing that's going on is that in addition to, what's it going to cost, is how is this going to impact my personal convenience? And I made a few notes there at the bottom of the page in terms of what patients are really looking for going forward. All things that need to be taken into account as you consider the acquisition of new technology. Healthcare providers are also looking at how value has changed over the course of the last few years, and their expectations really now are much higher. Pre-pandemic, people were looking at 5 to 10% in healthcare providers to make a change in brand or a change in procedure or that sort of thing. Because of the distraction caused by the pandemic over the last few years, value, not just necessarily price savings, but value needs now generally to exceed about 10% for people to take it seriously, because they are still very distracted in many providers in terms of providing vaccine, recovering and getting elective procedures back on track and that sort of thing. And so it's really another reason why clear value propositions are very important in making your case. The new normal, just a couple key points here. I think as we go forward, there's going to be fewer in-person meetings, so making your points virtually, whether you're in a provider, is very important. I can tell you that at the Mayo Clinic in Rochester, at Froedtert in the Medical College of Wisconsin, and a whole host of other places, they're now saying that many of the people who work in administrative positions, particularly in supply chain, capital acquisition, in those areas, are going to continue to work from home. They're not coming back to an office. And so being able to do this virtually is, and having compelling visual presentations is key. And then really virtual follow-up and follow through is probably another important piece of this as well. So if you're looking at accessing group purchasing, they usually have a 3 to 5 year contracting cycle, but they also have new technology forums and events, new technology introductory processes. And so if you're shopping for new equipment, your group purchasing organization at the national level and even at the regional level is a key area to consider in terms of what technology they have. And then on the right-hand side here, I've just sort of replicated a typical value analysis process and how that looks. I think when you've seen one, you've seen one. But typically in the value analysis committee, you've got physicians, nursing, department administration, somebody from IT and analytics, revenue cycle management, finance, and supply chain. And so making your case to these folks at all these different levels is very, very important.
As a physician, let's say I want to have a new technology. I'm just kind of trying to break it down to a language where, as physician, we're understanding. You're doing a phenomenal job. But does that mean if I need a new wire, a new stand, whatever device I want, first I have to know if my health system is part of a group purchasing, number one, and then how can I start the process and where to reach? I go to the headquarters. Is there a sub centers where I should reach out in order to get this technology? How does it work?
I think that's a really good question. And I think that the supply chain and purchasing people within your facility can be helpful with that. And it's not to suggest that you have to use a group purchasing contract. At least my philosophy when I worked in hospitals was, we're going to get you whatever you want. But if the group purchasing organization has it, that's a head start. And we can find out more about the technology with them. We can provide more information to you around cost and that sort of thing. And so I think it's a good way to start building your case. That's an excellent point, Chadi. Did that get to the
Yes,
question?
thank you.
Okay,
Yeah.
good. So it's sort of building off of that, that's kind of a nice segue, is that one of the things that we've done, and this is a real example from OpSense, this is what we call our 2-pager at Access Strategy Partners, and it's applicable to value analysis. This is actually a format that was developed between Access Strategy Partners and the Mayo Clinic, and we use their value analysis team to help us build this. Very simple. They were frustrated because oftentimes firms come in and they have 40 white papers, They have in their backpack a whole host of information, all good and all good for backup information, but tell us very succinctly what this product does, the clinical value of the product, and then what the economic value is, not just the price of the product, but what else it does in terms of cost and use, the reduction of readmissions, shorter length of stay, all of those types of things. And so we highly recommend that if you're making a presentation to a VAC committee, that you distill the message down to 2 or maybe 4 pages, depending on how much space you need, or if you need a diagram or something. Clinical value, economic value, and anything else you feel is important for the committee to know. So this is one way that we see communicating value succinctly if you're getting ready. And a lot of this information, supply chain and the company can provide as well if you're making a case. And OpSense is very good at providing information that will help individual physicians make their case in front of a value analysis committee. Another thing that many companies are doing today, and OpSense is certainly one of them, is use health economics to validate the value. Oftentimes people get in front of a value analysis committee and they have a lot of good qualitative information about a product, but what does it really mean? And what does it mean to the patient? And what does it mean economically? And so taking a look at, and this happens to be for OptoWire, but taking a look at annual cost savings in various modes. And again, this is something that many administrators are looking for today, is what does this really mean? What's the clinical value? That's certainly number one, but what does it translate to in terms of value to the patient and in terms of the organization going forward? The third area is really trying to evaluate the product among perhaps many physicians or many on the staff. And so constructing, and this is just an example, but it's an example that fits well into SurveyMonkey and other analysis tools for collecting survey data. You can really quantify what people's perception of products is by doing this. And so we recommend oftentimes that you gather information like this if you're doing product evaluations and you have to take them to a value analysis committee or to a departmental administrator. Fourth area, and this kind of goes back to what Chadi was asking earlier, is having some of this information. And this is information that would reside in the supply chain department. It's a contract summary for OpSense. It's for a contract that's going to be launched, we hope, in the very near future. And it has a lot of information. We've kind of blinded some of it out of here, but it has pricing tiers and it has all sorts of things. And I'm sure Eric is very familiar with taking a look at these types of things and using them on a regular basis. And it's something that supply chain, purchasing, capital equipment acquisition, or other buyers can use to help inform you in terms of the pricing decisions that are going to be made and that sort of thing. And this ties back to the use of the group purchasing organization. If you're not going to use a group purchasing organization, this information can still be summarized pretty easily. And then forming a basis of collaboration, I think, between supply chain, revenue cycle management, finance in the hospital, as well as collaboration with certain suppliers, is very, very important. And this is just 10 key things that collaboration is built on. This is work that I did a couple of years ago, actually, for the Strategic Marketplace Initiative. And it really talks about some of the things that you need to do in terms of building collaborative relationships, whether it's between departments within a healthcare provider or between the healthcare provider and the supplier and all of those types of things. One of the other things I can tell you that most hospitals are asking about today and many administrators are asking about today is, can the supplier supply what you're evaluating? And this is really an example of drugs, but med tech products follow the same kind of shortage patterns. And in drugs, some of you are probably aware that healthcare hospitals, ambulatory surgery centers, clinics have gotten so tired of drug shortages that they've started manufacturing some of their own. And so companies like Mayo, Common Spirit Healthcare, Ascension, and others have actually invested in a drug company that's going to be located in Virginia, in Virginia, and start producing injectable antibiotics in the next couple of years, as well as several other things that are in short supply, simply because they can't get the products from traditional manufacturers. So when the pandemic passes, I think just a couple of key points here. People are still going to be working at home. Many committees are still going to be virtual. And so understanding the process is very important. And then I think it's price sensitivity that's probably going to continue in the long term. And I just call your attention here to a couple of quotes. One is from the CIO at Providence Healthcare. We're focused on the future of healthcare delivery, and it's the patient that's at the site of care, at the center of the care, not necessarily the hospital at the site of care. People told us 5 years ago, 10 years ago, that the hospital would no longer be the center of the universe, and in some cases now, it really is becoming the an expense center in terms of where care is delivered. So those are my comments for tonight. And Chadi, I'll turn it back over to you.
Thank you so much, John. I mean, this is really great and thoughtful slides. I mean, and talk for us. The for the audience, we put a poll there for you, so get your thoughts. But at the same time, John, you showed us the way that how as a physician we need to show to the administration as well as to the purchasing team the value of technology. From me as a physician, or I mean, my worry is I have a new technology, Opsens Wire. It's reliable. I can do multi-visual IFR. I can do PCI on it. I can do post-PCI IFR. So this is what the knowledge I have about the wire, and this is what I think helped my patient the most. The things beyond that you mentioned, which is nicely illustrated, is about the cost effectiveness. I don't know how to do cost effectiveness analysis. Who should be that person in my institution to help me with this analysis to make a case for a new technology?
Well, in many cases, it can be purchasing or supply chain, but it can also be people in various departments. So for example, infection control, if the product is going to reduce infections or hospital readmissions, people in infection control could possibly do it. In terms of reducing length of stay or readmission or those types of things, finance could probably do it. Another area is certainly having an IT analyst at your disposal to help make cases, and many hospitals now have them. And so it sort of varies by exactly what you're looking to do. But those people that I noted on the value analysis committee are the ones that should be able to guide you to help do that. And somebody that leads the steering committee, for example, of your value analysis team should be able to help point you in the right direction for that. And by doing that, you're starting to collaborate with them already, and it sort of helps in terms of them helping you make the presentation.
Absolutely, and it's really crucial to know these pathways, because I see a need, but one of the first thing hits me: how can I get this into the lab? The other question I have is with the COVID and the patient understanding that they are now searching healthcare. Where can they do procedure as an outpatient, and which cath lab or which hospital have this new technology that will give me the best outcome? Is there some website, or is it something? Is it industry that already focus on consumers, such as the patient, to look for this information?
I would go to your marketing department. Your hospital certainly has a marketing department, and I would talk to them about it and see how and whether they think that this is a promotable procedure. And I think in this case, it certainly is. And see what their feelings are about it, and talk about how they might help the department promote it to consumers.
Yes.
I think that's a great place to start in that case.
Awesome. All right. Moving along to Kerry Riddick. She's going to talk to us how to bring new innovation to the cath lab. Kerry Riddick is in charge of strategic direction and oversight for the interventional cardiology program at Atlantic Health System, inclusive of 4 hospital cardiac catheterization labs, electrophysiology labs, the structural heart program, the mechanical circulatory support program, and the heart success failure program. Over the past year, Ms. Riddick has been developing network-wide processes for the interventional lab, including a staffing pool, collaborative governance committee, a SEMI committee, and a supply inventory utilization team. Kerry, so pleasure and to have you here with us today to talk about. You have a tremendous experience. You work with different physicians with different backgrounds. So delighted to have you on the webinar.
Thank you, Chadi, and thank you for Opsons for inviting me to be here. And I'll tell you a little bit about our story at Morristown. Many of the points that John made, I'll be kind of overlapping with, and were very valid. So to tell you a little bit about Morristown, we're located in northern New Jersey, and we have 5 acute care hospitals in our system. This is our tertiary care hospital, Morristown Medical Center, where the Gagnon Cardiovascular Institute is located, and all the happy good things happen in cardiology world. We just recently added on 2 floors. So we now have a 5-story Gagnon Cardiovascular Institute building, which we're pretty excited about. Some of the program highlights: we are the highest volume cath lab in the state of New Jersey, and we're ranked number 4 in the country for our TAVR volume. The year before, in 2019, we did 607 TAVRs before COVID, and during our COVID year, we still managed to do 473. We just recently received ACC TAVR certification recognition, and we're one of the highest volume CT surgery programs. So just a lot of national podium presence with our docs and administrators and nurse practitioners, and we're very committed to research. One of the really exciting thing is we have a devoted structural heart unit in the region, which I don't know of anyone else that does. So that was kind of a big thing. In our cath lab, we do about 30 cases a day. That's on average. We do anywhere. We do up and over 40 some days. We have 50 interventional cardiologists that come to our cath lab. And in 2020, we opened a new cath lab, an additional room. So we have 6 rooms now, and we have a radial suite, which we just opened, and right in the middle of COVID. So here we wanted to make this patient experience really wonderful, and they could get up, walk around on the side with all the couch looking chairs. There's a coffee bar, the whole 9 yards, and yet we haven't been able to let one patient get up and over there because of COVID. But someday we'll get to use this the way it was fully intended. We have 70 team members in the cath lab and 30 in EP, so we have about 100 staff members, and we're committed to providing the latest technology through research and innovation. And I'll talk to you a little bit about how we get that technology through the door. Akin to what John was saying about collaboration, it's all about partnerships. And we know we have to work with our physicians and industry and strategic sourcing, finance, and the staff. And everybody kind of has a say in what's going on, and how we're a little bit different in cardiology, as you're going to see, how we do our value analysis. We have our own little program for doing it. And we find that it's necessary to partner with our industry and the vendors, and they often will ask us, well, how do we fit into this? And how do we get through the door? What do you need to know from us? And how can we help you get our technology through the door? So where I feel like the best way we could start is for our hospital is for industry to find somebody who's a physician champion, somebody who's interested in using the technology. And it helps for us to be involved in clinical research because we're right on the cutting edge of what's out there, what's new, and to have a culture of positive change. If people on the webinar are from cath labs, they probably know that cath lab staff can be quite challenging, and leadership's one of my biggest passions, and we have a very good, healthy work environment. In fact, when Charles came from Opsons came to visit us, many times vendors will tell us, and he pointed out as well, how great the staff is to work with. So I think that's a really important to be able to bring in new technology. For industry, after you've identified your physician interest, it's really important for you to find out who are the key hospital decision makers. When I've spoken to industry before, they all seem to think that the physicians, no offense, Chadi, but the physicians are the ones that are making all the decisions about who's purchasing. And that's just, over the years, that's just changed. You need to find out in your hospital who's the one. Is it one person? Is it a committee? Is it a physician? And identify who to reach out to. It's always a good idea to start with that frontline cath lab leadership. Who are they? They should be your first stop, but they may not be the people who are making the decisions about what new technology to bring into your lab. So ideally, it's most important to find out who holds your budget. They're probably the one that will make that final decision. So is that your cath lab manager director, or is it the CV service line director? It's probably one of those two people that will be making the final decision in conjunction and partnership with the others that were listed in previous slides. So I work very closely with our cath lab medical director, and he'll often come to me as some of his colleagues will come to him and let him know what's coming down the pipeline in industry and what they're interested in participating and looking at for new technologies. So there's a lot of discussion around. I have monthly meetings with our cath lab director or anything else that comes up. In addition, I don't even usually speak with a vendor until alone. I'm very partnered with my cardiology strategic sourcing rep, and we discuss everything from contracts, pricing. She verifies all the HPG details, and we meet head on with all the vendors or anybody that wants to bring new technology in. So as time has gone on, we've gotten more and more cohesive working together. And again, we just don't meet at all with anybody without the two of us as a team.
Kerry, question:
Yeah.
Who's the strategic sourcing partner?
So she's in sourcing, and she's over all the cardiology service line. So her and I, just everything that comes through the doors or renegotiating contracts, we do everything as a team.
And is that person sitting part of the Atlantic Health System or Morristown
Absolutely,
Medical
yeah.
Center?
Yeah, we have our own strategic sourcing department. I think most hospitals probably do, but yes, she's actually been working from home a lot, like John said, but they are back now. So, but we still aren't having in-person meetings. I don't think that's going to change, and I think it makes it a little bit more efficient.
So me as a physician, then I have to find you first. You're gonna sit. We're gonna connect me with strategic sourcing partner, and then take it from there.
Yep.
And just to be clear, the strategic sourcing is part of supply chain. I think I use supply chain pretty generously, and strategic sourcing is one element of the whole supply chain.
Oh, I see. Okay.
Agreed.
So questions that I'd ask industry to come prepared to talk to about is, what is the scope of practice for your device? What limitations are there? What patient selection do you think this is this technology is most appropriate for? And I always want to know, is there any trials or studies to support your device or technology? Does it bring any additional reimbursement? That's one of the first things I'll ask when they come forward, because I'm going to be held accountable for talking to the CFO and to the finance department, all the way up to the system CFO will ask questions because of the large amount of money that cardiology spends in the span of control that I have with purchasing, and even structural heart. Probably everybody knows how expensive the structural heart devices are. So I'm always looking at if we're bringing in a new technology, is there the new technology add-on charge that we can get at least some of the cost of the technology reimbursed back to us. I'm always, when new technology comes in, one of the things I always ask to do is speak to the economic reimbursement specialist from industry, because I want to know what it is that they know about when do we anticipate getting reimbursement. I think it's kind of cute. I've actually had a physician say to me, I said, well, we're not being reimbursed for this technology yet. And he said, well, that's okay with me. And I said, it might be okay with you, but it's definitely not okay with the CFO. Sorry, we're gonna have to wait. But anyway, so I find that, educating my physician partners is also part of my role. So, and then also I need to know what types of deals on the table. Are you part of HPG? Do you do local contracting if you are part of HPG? Is there any opportunity for volume-based rebates and bulk purchases? So those are the kinds of things that I'm looking for when new technologies coming through the door. So we really are a partnership between industry and the hospitals, right? So we're going to buy your product and that's your win, but you're going to save us money or bring us additional value. And John mentioned this as well. It's the additional value that we're really looking at in healthcare right now. It's not just how many dollars you're going to save me, although that is important, especially after COVID. But I want to look at what other types of things are available. Is there educational opportunities? Is there the opportunity to network with other people's sponsorships, symposiums? Those are the kinds of things that we like to look at. Is there an opportunity to do research together? I mean, we're looking at the whole value-based add-in when we're looking at new technology as well.
So Kerry, let me pause here for a second. And Eric, I mean, we might go over time, but that's all right. Second bullet from the first box, you
Yeah.
should save us money or bringing us additional value. How come as a physician, I should figure this out? It's you, Kerry, and the sourcing?
How can you figure it out?
Yeah, how can I bring this technology? You're going to save us the hospital money.
Right. And I'm not quite sure, Chadi, I understand your question.
How do me as a physician,
Mm-hmm.
figure out if this new technology going to save money, is cost effective?
Okay, so I don't know about you, but when I always speak, actually the docs just brought me something today, and one of the docs went to the medical director and he brought it to me, and we looked at the price of it together. I will always find out what these questions, and get the answer to these questions, and then I'll bring it back to him and we'll discuss the price, and I'll show you how we're very transparent about pricing with our docs.
Good.
So as a hospital administrator, my concerns are not just the financial challenges, but all the regulatory agencies in the world that are coming through and looking at our processes and how we use technology, and of course patient safety and quality. So there's a lot that we're thinking about just besides technology and the cost, but the financial considerations are quite formidable, right? So we are all looking to CMS, since nearly 60% of our patients come from our CMS patients. And also, if you look at what's going on in the world of healthcare, most CEOs, their top priority is going to be looking at the finances, the rising supply costs and trying to figure out ways to reduce our operating costs. So it's all, when I have to present or ask for new technology, I have to be very savvy about the finances surrounding this technology. It's not just about what the technology does. I have to show why that's going to work into our financial picture. So frequently when we bring in new technology, it's not going to be, I'm not going to have a budget for it. So you're bringing in something that I already am going to be in the hole when I start to purchase, right? Because I didn't plan to use this device. So when we do variance reporting and put in why, all right, well, there was new technology that came in, so I can explain why I'm $58,000 over budget in this category, then what's helpful to me is that it's going to roll over into the upcoming year if we continue to use that technology. So how do we do technology, bringing in technology at Morristown? I think the best thing is for the industry to make an appointment with the budget holder, which in this case is me, discuss it with the physicians, and then we have an interventional cardiology meeting once a month, and we allow industry 5 minutes to come in and hit the highlights of their whatever technology or product they'd like to share with the interventional cardiologist. I mean, you're getting an entire group of them all at once. It's sort of a great opportunity. And then this is where things can really get held up. If we decide that we're going to go ahead and have a trial, there's a bunch of paperwork that has to be sent in, right, to strategic sourcing, and they have their own legal department. So this doesn't always happen quickly. So this I find in bringing in new technology that often the industry or the vendor will think that, okay, great, you said, okay, let's bring it in. And it doesn't work that way. And, I'd be glad to hear what Eric and John have to say about this, and if their legal departments are any faster than ours. But there's a lot of redlining that goes back and forth between the vendor and our legal department before they even come in and are allowed to do a trial or an evaluation. So this takes time. It can take a couple weeks for this to happen. So nothing happens very quickly. And once that happens and we have approval from strategic sourcing and legal, we can bring the new technology in and we enter it into our system. which is McKesson POU, and we're ready to go then. We can bring it in, and that paperwork has to do with the FDA approval, all that stuff. I mean, there is times when the physicians will come to me and say, they're gonna be getting FDA approval really quickly. Can you get ready and move on this? And so, I mean, that's how some of the physicians I work with are really excited about trying new technology. So we will get everything we can ready to go. So when they get the FDA approval letter, we slide it over and we start getting the paperwork done so we can bring that new technology in.
And Kerry, how do you find out, let's say somebody new hire, how do you find out who's the budget holder? Start with the cath lab director, start with the chief of cardiology.
I would absolutely start with the cath lab leaders. They may be that person, or they may have somebody that's a service line director over them that's that person, but they'll know who is the one making those decisions.
Yeah. And for research, you mentioned research, let's say as a device or a contrast medium or whatever it is to bring it, is it something negotiable for the price for the product, or usually for research, usually these are covered 100% by the trial?
No, they're not always covered 100% by the trial at all. So yes, I mean, most of the time when somebody brings something new in, that's not so much the time to negotiate pricing. We'll do the evaluation in the trial, and then the negotiating for pricing and things happens after the decision to bring it in, or when we're deciding to bring it in or not. But first we'll trial it and see if we like it, and then we'll and if we feel like there's value to the technology, then we'll go back and have a conversation with the vendor about pricing. I mean, I'll say, sometimes there's inflated initial pricing, as you probably know, as people are trying to get the highest reimbursement they can from CMS, so they'll kind of inflate their initial product price, and with promises, of course, to bring it down later, or and so that's kind of how it works, or promises that they're going to get an NTAP or some new technology add-on reimbursement.
Right.
So this is kind of a reiteration, but the trial and the evaluation, we do have evaluation forms that are filled out, and we do discuss it at the next IC meeting, the interventional cardiology meeting, to make that final decision about whether we need to move forward. And while this is going on simultaneously, I am looking at, I know what the contribution margins are for the different procedures that we perform. So I know how much this is going to impact the contribution margin. So other considerations that we look at during the value analysis process, and I did tell you we're different than a lot of other hospitals, because cardiology itself, we don't go to some big committee. It literally is the process I just told you. It goes to the interventional cardiology meeting. Then we make a decision whether to go. We're pretty independent except for our partnership with Strategic. It doesn't go to any other committee. So it's just our group that really looks at our cardiology products. So these are the kinds of things that we're looking at. What kind of education and support is offered with the new technology? Is there any other products that are in the same, are doing the same thing? And, and that's how we'll look at it. And then there's the contracting. And I'm not going to spend a lot of time on this because I know we're running a little bit over, and John covered a lot of it. So, once we've decided to take it on, we're a part of Health Trust here at Morristown, which has formerly been called HPG. But John talked a lot about GPOs and the benefits and the cons. It's being very compliant driven. And they, same thing. This is kind of like the summary sheet he had. So I'm gonna kind of skip over that for now. The thing that's hard for us is if you're not on an HPG contract and you're bringing in new technology, it's going to go against the compliance % that we have to meet. So we have to buy a certain amount of product through HPG and meet that compliance. And if you're not on that HPG contract, then that will not count towards the compliance, number one. So that's something we do have to consider as well. And off contract, we will do some off contracts, some local contracting, S2 contracts, if it's something that we really feel like, even though the HPG doesn't have a contract with the company, but we feel like it's something we want to use, we will do a local contract anyway. as we did with Opsins. And that's about all I have. This is for Morristown. And does anyone have any questions?
Thank you so much, Kerry. Eric, John, if you have any comments, but this is really for me as a physician is an eye opener. I mean, at least giving me a lead to where to start. We do. I mean, as a physician, to tell you the truth, is we don't have orientation on these things when we start a job. Like, let's say maybe something we should start doing as or ask our hospital leadership to say, you know what, if you need something, this is you call this person and he or she will walk you through the rope to get your stuff done. But we sometimes we have to hop between around and wait for an email or somebody out of office till he get back and respond to your email and so forth. And this is kind of unfortunate, but it does happen, and it affects research as well as new technologies for patients.
Well, I appreciate your expertise in AV and helping me get my PowerPoint up on the screen. Thank you, Chadi.
Always. That's a simple thing. For the audience, there's a poll there. For the poll before, when we asked them, do you have a group purchasing? Majority of them, 2/3 said they don't have no idea. So they are in the same boat like me when we said, we don't know how to start and we don't know if we are in a group purchasing hospital or not. So this is something, a serious problem. And I think we should do a better job orienting our physician to what to do. With that, I would like to introduce our third. Thank you so much, Kerry, for your time and John so far. And let me introduce Eric. Eric Brown is worked in the supply chain of an academic medical group in the Northeast for 15 years. He started in physical services and worked in the OR and pathology department. His present role is that of a clinical contract manager for the institution. His present area of oversight include cardiology, radiology, and GI. He is certified materials and source professional and received both his undergraduate and graduate degree from Northeastern University. Eric, thank you so much for your time. I really
Thank you, Chadi. I'm in the supply chain. What happened with the supply chain and its response to COVID really kind of backing up here. There we were, mid-March, working in our offices. And suddenly we were told we couldn't come to our offices. Stop whatever you're doing and try to find some PPE now. And then I'm at BIDMC, which is Beth Israel Deaconess Medical Center, which is part of Beth Israel Lahey Health, which we were recently merged at the time. And so there we were, new VP, trying to all work from our basement. Some of us were teaching our children as well. And we're in this phase of trying to buy stuff we knew nothing about from people we had no idea who we were dealing with. So it was a shift right away. Got to get the N95s. I wound up meeting a person on a side street because they developed some prototype thing that was like a snorkel that I took to our infectious department. They were like, we can't breathe through this thing. I mean, we were literally trying everything, working 12 hours a day. And it was funny because we were almost the salespeople chasing leads and trying to get anything. So bad that I called my new VP on a Sunday because my boss went down with COVID and was out of commission for a while. So we saw the surge in New York and we were like, well, this is coming up to Boston. So get those N95s. Called my new VP on a Sunday. I say, will you front $2 million for some N95s over in another country? Thankfully, that idea got 86 by him, or I might be using this very platform to peddle some bunk N95s, but we nonetheless, we got what we needed. Our team was together and people appreciated it. We saw the nurses, the doctors, obviously all those frontline people get the recognition that they so undoubtedly deserved. But I also, part of my time was in the pathology department, literally built 11 cost center budget at the line item level on pathology. I'm not a science person, but whatever. It gave me an appreciation for what the pathology departments do for the institutions. And I almost feel like sometimes they don't, well, I know they don't get the recognition from a capital standpoint at least, but I think all of us, I just would be remiss if I didn't mention the work they did. I think all of us have at least gone through the anxiety of waiting for a COVID test for either ourselves or a loved one to come back. And I really think we have those people to thank to turn it right around. So, and then, so success for the supply chain, but does it matter? Like, will it elevate supply chain to a more prominent, role within the hospital, as we're trying to push savings now with COVID and whatnot? Do we have any of that goodwill built up? My immediate answer is no, but I mean, my wife is she's a nurse also at BI, and we rolled out some syringes that were pushed by the supply chain to save money. And I actually got samples brought home and was told to go show my boss how awful the syringes were. So the cost savings, I guess, gets lost in that arena. But nonetheless, moving forward, now I have people offering me PPE constantly. I'm like, no, we're all good, but certainly the crush or the attention is still there to go find avenues for savings. So how do we as a supply chain do that? And again, I'm cardiology, radiology, and GI. I don't want to make any enemies or anything, but I will say cardiology gets my most attention out of that group. But work very well with them, and it's a very good relationship. I've been in my present role for about 4 years. So capital acquisition, that's one thing that's been talked about. How does it come in? Like, we have this wonderful rack process that runs every year, and people submit their stuff through rack and all. And that starts in April, and the funding would get released in October in a good year. That didn't even happen. Like, there was no rack process. There was no capital. We were told, like, yeah, if the parking lot caves in or something, we'll fix that. But you and your pretty machines or whatever, no. So we've seen these vendors start to continue to find ways to work around that capital process so that they can book those revenue streams with the disposable purchases. And I think COVID has only accentuated that maneuvering, which I think we as organizations have to catch up to that. And I mean, I'm given a list of what I need to look for when we're analyzing capital placement deals and whatnot. And the big sticking point is obviously it cannot adjust the supply, disposable price, and what have you. But the thing to remember too is nothing is ever free in this arena with capital. I mean, the quickest way I get yelled at by the compliance folks, and by how do you tell accounting departments to depreciate something that came in with no tangible on a no charge PO, or how, compliance is like, they're just inducing us to use it seems like this is inducement. So everything is scrutinized, and nothing is ever free. We are seeing, I used to rely a lot on bulk deals every quarter and be a mad dash to get the recs through at close and whatnot. We're seeing a kind of a pullback on that. It really from both the vendor, it seems, and certainly on the administration side. Like, in no way was I going to ask somebody, the CFO, for $1 million for TAVRs when we didn't even know if there was going to be a TAVR program or what have you. So we've stepped back in that arena. We literally bolts, I mean, they felt like they kind of handcuffed us to a degree, in that one of those TAVR bolts was for older technology that we literally would just use the last of. They found a valve, thankfully, or we were going to eat a very expensive device that would have mitigated any sort of, or taken a large chunk of the rebate we actually earned. So to stay fluid, we're moving away from those to a degree. And the physician, we're at an academic medical center. The place we merge with is also academic medical center. I only say that because we can't, in supply chain, hit the physicians over the head and tell them what to use. There's a lot of, there's certain it's just more complicated than that. And people are used to using what they are to use. So especially with the physician preferred items, I mean, you have to have a champion. You're right. That's the key. And I mean, the physicians have to hear about it. They have to advocate for it. People advocate to me about stuff. I'm like, you don't really save your energy, save your breath. I don't care. I don't want to really bring in a new technology unless somebody's telling me, hey, man, I want this. Let's devote our resources to this. Like deploying the resources and attention of a revenue department or a finance department to vet something out. I mean, they have to be willing to go to the mats for that because those departments are stretched and they don't want to just be passing in the night. I found a way to gauge how bad a physician wants something is how many times I hear about it from them. Or, you can tell right away with some of them, they're like, we need this right away. We want to be first or whatever. Got it. But then other ones, is this a rep that's just having, friendly with this stock, or where's it, is it going to rise to the top? So, and then another avenue we are sharing or seeing or across the country, it seems like, is gain sharing. Like physicians go into some sort of agreement with finance department, supply chain. Look, we'll use it, we'll change practices, we'll go to this or practice patterns, we'll go to this much less expensive product or what have you, or we'll focus our usage here if we get some of the windfall that's coming back to the hospital in some form, like obviously not in the form of pizza or more on Rubens later, but like improvements for the department, whether that's be like scheduling coordinator. One thing with COVID we've seen is the demands that it's put on scheduling procedures has increased because there's so many more steps involved, and that scheduling department is maxed out. Or even phlebotomists from my days in pathology. I mean, there was never enough phlebotomists ever. Somebody was always waiting too long or what have you. So it's ways like, can we get the physicians to change practice in a way that's advantageous for everyone so that they see some of the returns and it just goes back? Because I feel like in doing this for a few years, you do get your certain physicians that are like, yeah, let's save money. And they have these pipe dreams about, we'll see all the supplies we use in a case and we can have a competition and all this. It's great, but it doesn't, I mean, that's one person. And to get that buy-in, how do you get that? It's not the easiest thing. How do you sustain it too, after the initial buy-in? So those are some of the ways we're trying to find value as we move forward here. Which brings me to the OptiWire and how we brought it into BI. I mean, back when we met with vendors, Charles came to my office and we sat and I had heard about the OptiWire. I have a very close relationship with the lead interventional cardiologist at my hospital. We talk frequently. We're aware of what's going on in the market. And so that's kind of one thing led to another. And that's how the OptiWire was presented. And so met with Charles, and we're seeing a lot of transition in this space, especially as these companies are coming out with all of their versions to get the adenosine out. So we've seen, you see the blip when we presently have 3 to 4 wires just in our lab alone. So there's ample competition to see what holds water and what doesn't. That's a whole other subject, but whatever. So I just made it pretty clear to Charles, like, look, price matters. We're not gonna. And Options as a whole was very receptive to where they were in the market and what they were trying to gain, and the price. They brought value to our lab. It was good. So the product has to be good and it has to be literally available. I mean, when we have 3 other options and your product's not there, tough cookies. I mean, we'll just go to the other one. But with OptiWire, I mean, I talked to the technical director, who I'm close with, and we talk frequently about what's going on in the lab. I need that communication. I mean, I call it dimension. I literally haven't left this house in a year. Like, I have, but not for any sort of work engagement. I moved from the basement to one of the kids' rooms, which I'm in now. But so, I mean, I don't have that. I used to go up to the lab and just kind of not sit in the lab, but sit around and talk. That's gone. So I'm relying on those relationships that I had developed to tell me what's going on there. But the OptiWire, I mean, the staff likes it. It's easy to set up. They don't have to roll in a whole whole console into the room. It works. I mean, and that manifests in that they will, I mean, it helps grow the business. And the quality of the wire is comparable to our workhorse, meaning they're delivering therapies over that wire. And they're not changing out the wire and more fluoro, more time under fluoro. I mean, turning cases over in this environment doesn't seem to be as important, as our volume just hasn't returned to pre-COVID days at this point. But I mean, it helps when you're not having to just have the people or doctors got to change out the wire and whatnot. I just vouched for a very expensive product over in vascular, which its whole rip was, it's a wire, fiber optic wire that they can deliver the equipment, the stents for the AAAs and whatnot over the wire, and big reduction in fluoro, and people were receptive to that. I mean, you're starting to see more and more emphasis to cutting down that fluoro time, and anything you can do it's good. It makes me feel like I'm helping these people that are, I'm helping both the patient and the provider. It's not fair to them that they've been given all these gifts, but they still have to wear all this lead and be under this stuff just to help people. I mean, so anything we can do to mitigate that is good. And I told you, so this is what's unique about Options. And I know I mentioned Rubens before. I like Rubens. I used to go out to restaurants and actually get Rubens. Not that I go out to restaurants at all anymore, and I say it because Options is a wire company, is a sensor company, and they're really good at it. They got a good wire. They got a good sensor. It works. I sit through these godforsaken business reviews with a lot of these companies. No offense to business reviews, but I don't like sitting through them. That's one good thing I like about this Zoom stuff, is I can actually shut the camera off and kind of just be like, yeah, great. But so you sit with, and under these other companies have these big product offerings that can literally outfit every disposable aspect within the cath lab. They got a check mark in that box. Doesn't necessarily mean it's the best product. No, but they have a presence there, and they leverage that too by saying, oh, if you grow your business in balloons or, other things, we can see, rebate on this. And that's why Options has that. I mean, it's going to be, I would imagine, a challenge. I mean, because they don't have that wide product offering of all those check marks, but nonetheless, they have a very unique product that seemingly stands on its own. So kudos to them. And I looked at this little design that I plucked here last night, and I realized it's in the shape of the heart, this wire here, that's great. So good work there. So any questions so far?
Oh, you're great. Thanks.
Okay. So how does all this translate here? So Charles, this look familiar. This is my old office. This was where I was. I was right by Fenway Park. People asked me if I was a Red Sox fan. I was like, certainly I follow them, but when it's game day, it's literally a disaster. So no. But nonetheless, here's my office. The two in the picture probably listen to me about as much as the sales reps listen to me, so whatever. But it's all changed. I used to use that time in the office to sit and work with the vendors, talk to the vendors, get them talking. And that's where you get your truth. That's where you go. That's where I'm understanding the market. Like I cover cardiology, radiology, GI. I'm not saying that to sound more important or anything. It's a lot of ground to cover to be a subject matter expert and know how you're finding value for the hospital. It was a challenge. So I literally would just sit there face to face with the vendors, find out one of my first questions always was, what's going on in the market? What are you seeing? Like, what's the competitive? Because they know. I mean, supply chain, one thing we don't ever have to do is hit a number or anything like that. I only say that because the sales reps know what's going on in their industry, because that's how they're feeding their kids and all that. So they're receptive. I get information that way, and it's both. But now without face-to-face, I mean, is it Zoom? I'm thankful I have those relationships I built up over the years, because now I can just, call the people, whatever, we talk candidly. It's always very candid. But people just starting out or people I haven't met before, there's certainly a gap there. And, Zoom is great. I mean, we wouldn't be doing this without literally, a webinar this time last year. None of us, I wasn't fluent in Zoom. I'm still not, but I would have been like, I didn't even have a camera. So, I mean, it is changing in a way. Back to business reviews. I don't have people flying in to talk to me about, their market. I'm like, you flew in to talk to me. I mean, this is kind of a waste, but how do we foster the innovation? And it's through things like this and talking and communication. And I don't know, it's a challenge. It does. I mean, the reps, like we've talked about a lot, they're not getting into the labs. COVID's been we've seen institutions put up barriers, and I don't see it ever. I think the institutions as themselves, like the organizational control that they now are exerting over what they thought at the time, rep visits can, too much of them is a bad thing, I think. So this provided the lever to be like, okay, this is stopped, and how it comes back, to John's point, you got to be quick. You got to, you're not going to linger. So it'll be interesting, and then we'll just keep learning through mediums like this, and keep talking. I'm starting now to be like, I used to take a lot of outside of a business review. I always on a camera when I'm talking to industry or whatever, anybody, just so I can see them, just so like, are you schlepping around in a hat and a shirt, or are you actually, you care about this? It matters. It does. It's reasserting some sort of professional decorum. I think that went away a little bit. So Teddy Ruxpin's, the cord's been pulled on Teddy Ruxpin. I can talk about this stuff for a while, but I'll stop now. So thank you all for joining. Any questions?
Thank you so much, Eric. Definitely a steep learning curve for us as physicians to bring some technology to the lab. We have a question here. How satisfied are you with the pressure wire in your hospital? Again, I would like to thank the speaker for their time. Sorry for exceeding the time over the allocated time for the webinar. But I think take-home messages for me here is that number one is you should be, as a physician, before you bring any new technology, you have to be patient-centered and patient-focused. Is this technology going to improve patient outcome and going to expedite care in the hospital with or without COVID? And number two, to learn your key players in your institution, starting from the cath lab director and then all the way up. Different institution, as Kerry illustrated to us, different institution has different hierarchy, and the stakeholders are different in each hospital. John nicely illustrated the fact that the purchasing as well as the demand and the need for the market is completely different. And as a physician, you have to learn these new tools to accommodate your practice and your patient needs. And Eric, I mean, definitely he did a wonderful job mitigating how to meet with a vendor, how to negotiate, and how to bring the cost into the lab lower to bring most effective care with the lowest cost. Thank you for your time.